You're listening to Community Health Watch on WNHHLP 103.5 FM, New Haven's home for community radio. Insightful conversations, impactful ideas, and voices shaping our community and beyond. Let's begin the dialogue.
Good morning and welcome to the YCCI Community Health Watch show. We're here today, Reverend Clayton and I, with our special guest, Dr. Charles Werner of emergency medicine, who's also just an outstanding professor of medicine. He's a board certified internal emergency medicine with specialization in stroke and emergency critical care. But more than that, he is one of the physicians that you would want at your bedside. He is so down to earth. He comes out to the community, and he's here today to help folk understand the new study that he's doing dealing with epilepsy and a drug called ketamine. So, Dr. Werner, you want to just give us a little update about yourself and how you got interested in this particular study?
Yeah, thank you. Thank you so much, and thank you for the very kind introduction too. And it's a pleasure to join both you, Reverend Perry, and Reverend Clayton, and all the others today to talk about this trial. And like stated, background about myself: I work in emergency medicine at Yale. I trained in Detroit, Michigan, before coming to New Haven, and have a special interest kind of in neurological emergencies, which are kind of broad and encompassing, inclusive of stroke, seizures, and other similar conditions. And so again, thank you for the opportunity to talk about the trial that we're going to be starting later in the fall, early winter, seeing if a novel medication for seizure use can work for seizures, a subset of seizures called status epilepticus, which are refractory to conventional treatments. For background about this study first, we are at Yale. We're a part of a national clinical trials network that's funded by the National Institutes of Health out of Washington, D.C. We're participating in other clinical trials for traumatic brain injury, cardiac arrest, and this study, like stated, is also funded by this. We are one of 60 sites that are going to be participating in the trial. It's going to be national, from the Pacific to the Atlantic, with many cities in between. And again, it kind of, the focus of this is to see if this medication called ketamine can work for seizures that don't stop with conventional medications. And for background, ketamine is a medication that really has undergone a lot of evolution. It does modify some of the neurotransmitters in the brain, and traditionally, like 20 years ago when I was in Detroit, we really only used it for sedation in pediatric patients. So if a pediatric patient needed a procedure or had a dislocation of a joint, we would use this short-term dose of ketamine to place them in conscious sedation, perform the procedure, and then ultimately, after like a 20 to 30 minute wake-up time period and further surveillance in the ED, they'd be able to go home. Over time, over the course of the past couple of decades, we've seen an expansion of its use into adult patients for sedation. And then we've even seen an expansion for severe bouts of depression. And then ketamine kind of had background history as being like a third or fourth, or even in some cases a fifth line agent to stop these super refractory seizures called status epilepticus. And this trial, following some preliminary work, is looking to see if moving it up earlier in the use for status epilepticus provides benefit for stopping seizures quicker.
When we talked to Dr. Crystal, who 25 years has been working with ketamine and mental health patients, he told us that it was not readily available outside of, for him in his study, outside of patients who had were resistant to other medications for mental illness, And so then ketamine became available. So he's been using this for a while, and we've interviewed him a number of times.
Mm.
And you know, when he talked to us, he told us that the medication was expensive. He told us that it was not used for in just everyday work. There had to be these requirements put in place in order for them to even use to treat mental health patients with it. And then there is the idea that you're using ketamine, which is a drug that we've just noticed that people are misusing, and some have even died from it. So it has a kind of stereotypical kind of frightening part to it, I think, that our community probably needs to hear from you about in terms of its safety and efficacy. And then how do you really deal with people who've already got a mindset that this is a drug, that I may get hooked on it, or that I may have some bad side effects to it. I mean, so you're the doctor, you're the expert here. So tell us how you work that out in the scheme of things.
Yeah, those are great questions and very important questions as well. First and foremost, for further background about ketamine, it's a medication, as you alluded to, and as I alluded to in the timeline, can only be utilized in the hospital or pre-hospital setting with administration by, certified professionals who have the ability, capacity, and expertise at doing all of the surveillance and monitoring that needs to be done with any medications that we use for conscious sedation, or any medications that are used, with similar sedating effects. Ketamine, as you said, that it does, have abuse potential. The one thing about this trial is that patients are only going to be receiving a one-time dose of it, and we can go further into kind of like the different aspects of the protocol. But bear in mind, for background, just for general background about this condition called status epilepticus, of which is a very serious complication of epilepsy and a very serious complication of seizures. It is something that does, it is a condition that can be very, very serious, and in some circumstances can be very dangerous, and maybe possibly even life-threatening. While there are nearly 3 million people in America who have epilepsy, thankfully, there's only, per numbers that I looked at, 100 to 120,000 per year in America that have this complicated status epilepticus condition. And again, for background, status epilepticus, it is continuous, ongoing, convulsive or non-convulsive seizure activity that is refractory to other traditional first-line medications like Valium or medications similar to Valium, like Ativan or Versed. And status epilepticus as well may be refractory to some of the other traditional medications that we give in the emergency department, like Keppra or fosphenytoin or valproic acid. And so, the overarching, one of the overarching aims is that, there's a great possibility of a much greater benefit than there is harm from this. Because ketamine, certainly in the hospital setting, we know some of the physiologic effects that it can do. Like the reason why it was utilized in pediatric patients first before adult patients is because it can increase the heart rate a little bit. It can increase the blood pressure a little bit. You can have kind of what's called a dream state emergence like reactions with it as well. But thankfully in the hospital setting, it is a very safe medication to administer in the recommended dose ranges that it's given. Part of the issue as well, which, some of your listeners may be aware of, because there are, famous people in our society who have died from ketamine overdoses. Ketamine, like many other medications, if it's given in excessive dosages, that's when you can, certainly have, some of the very serious further side effects that can occur, affecting the brain, the heart, the lungs, and the breathing rate. But for the most part, the dosages that we give in the emergency department, the dosages in this trial, are very safe. And personally, in my 20 years to 25 years of using this in patients, I've never seen an untoward complication that has required patients to be admitted to the hospital or have further interventions that are performed. And when we talk about kind of like the trial itself, again, the patients entering this trial will be those of the subset seizure patients who don't have seizures stopped by medications like Valium, and have seizures that are occurring for more than 5 minutes, which is the time criteria for status epilepticus. And then the patients will be placed into one of three arms. The first arm, they will receive the traditional med that at Yale and many sites we use among the first-line hospital medications. They'll be given a dose of Keppra in the first arm. In the second arm, that will look at low-dose ketamine. And then in the third arm, in addition to Keppra, all patients will be receiving Keppra. And in the third arm, there will be moderate dose ketamine that's given. And so all patients in all arms will be receiving Valium by EMS and the emergency department teams first. All patients will be receiving Keppra, and then we have low-dose ketamine on top of the Keppra and moderate dose ketamine on top. So at the dosage ranges that are being given, 1 per kilo and 3 per kilo, that's typically within a very good, safe dosage range. Again, ketamine doses, when you get above 5 or 10 milligrams per kilogram, that's when you can get untoward further side effects. And the reality is too, anything given in excess in medicine can certainly have potentially harmful effects. So thank you for bringing that up, because that is a very important thing to consider. And again, the fact that we are just giving a single dose of ketamine, that really poses a negligible risk for dependence or addiction, as well, as you alluded to as well. We're not going to be giving recurrent dosages of this. It's just a single dose. So,
Doc, what is the population your study is focusing on for this particular study? And the next question I have, you probably answered it to some degree. Who can be a part of this study?
Thank you for asking that. So first and foremost, the age range. This is a study that's going to be for pediatric patients above the age of 1, extending through adult patients without any cap of the age. And again, like stated, status epilepticus, thankfully, is a relatively rare complication of epilepsy or of seizure activity. At our site at Yale, we probably only get at most 10 or maybe 15 patients per year, while we see thousands per year who have like single first-time onset seizures or known established refractory seizures that respond to the medications that we give. So it's going to be for pediatric and adult patients. There are, for many clinical trials, there's a long list of exclusion criteria. So if patients are known to have a allergy to any of the medications, they'll be excluded, or side effects from Keppra or ketamine, they'll be excluded. Pregnant patients will be excluded, to highlight some of the rigorous exclusion criteria that exist for these trials as well. The other key thing for this trial too is that typically, as perhaps many of your listeners here today know, is that for clinical trials and research in general, one thing that is required is to get informed consent from from patients or from family members. But this is such a hyperacute clinical trial that it has met criteria by the FDA established exemption from informed consent procedures, and so other patients that will be excluded are those that choose to opt out of our trial. And so, as we've talked about in the past and seen you at some of our events, we've done a fairly, rigorous and involved community consultation plan with multiple events in the community, advertising on Instagram and Facebook. And this is all in partnership with the central sites that are coordinating all 60 centers, and have provided further dissemination of materials related to the trial and different clinics and locations, so as to give people the opportunity to learn more about the trial, but then to opt out if needed. Because again, when we look at the timeline of the trial, when a person is actively seizing, they obviously can't provide consent, and it is a critical, time-sensitive emergency as well. And so oftentimes the ambulances will arrive to the hospital before family members, and we know that minutes count for breaking seizures. And so we've kind of gone through this community consultation and exemption from informed consent procedure to try to give the public, every opportunity, if desired, to opt out of this trial. And we did participate in a past similar status epilepticus trial about 7 or 8 years ago, that tested Keppra versus fosphenytoin versus valproate. And we did go through a community consultation plan there, partnering with the State of Connecticut Epilepsy Foundation, as we are here as well, I forgot to mention, performing community events, partaking in support groups through the Connecticut Epilepsy Foundation. And we actually, through that process, we had no people that were identified who chose to opt out of the trial. We did have people ask if they could opt in, but that's not an option for either one of these trials. And obviously we don't want people to have this complication from seizures of status epilepticus as well. But and again, I thank you for the opportunity to share information with your listeners about the trial. And if anybody wants to learn more or contact us, we can provide your trial email address so that people can reach out to myself and our coordinator about this.
Great.
Awesome. This is such a fascinating subject. I think we could be here all day long. Listening to NHH 103.5 FM radio, community radio, and just want our listeners to know how appreciative we are that they're listening in and how important this information is to have. Now, Dr. Werner has also mentioned the fact, and I've been to a couple of events where he's been in the community and he's talked to people. And, one of the things about being sick is that it has with it a stigma that you're not healthy, that something is wrong with you. And so, many people shy away from even admitting the fact that they have seizures or epilepsy or any number of health issues because of the stigma that goes with it. But I noticed that a couple of our fairs, people came up to you and they were just interested in talking with the professional who could just share with them this kind of information. Do you have any anecdotal stories from these health events that you've gone to? I've seen you holding babies like you were a politician, but I know you were.
Oh, that was a privilege that day, without a doubt. So, yeah, I mean, that's one of the amazing things about just kind of engaging with the community, and one of the things that, really for like researchers like myself too, kind of, further galvanizes, our, desires to contribute in these trials to new scientific discoveries, which will help our patients. And certainly this trial has great potential. If it does have, the outcome of demonstrating beneficial effects of using ketamine sooner, it could help patients significantly. But as you said, one of the amazing things, I mean, We went to several community events with the Junta Foundation, the Vera Community Festival, with the Zion Methodist Church on Dixwell. We were at one of YCCI's events, to name a few. We did a webinar with the Connecticut Epilepsy Foundation. And as you stated, one of the amazing things at the Junta Festival, we had 6 people come up to us who had epilepsy. At the Zion community, at the Varick Community Day at the Zion Methodist Church, we had 12 people come up to us who had epilepsy, including a grandmother with an 8-year-old who had just been diagnosed with epilepsy 2 weeks prior. We had 2 people, a mother at the Junta Festival, and then a patient themselves who had seizures when standing on stairwells and had secondary falls and actually suffered neck fractures from them, just underscoring how scary it is to be a family member, or especially to be a patient living with epilepsy. Because seizures, if they occur at the wrong moment, when you're driving, when you're swimming, when you're on a stairwell, when you're operating potentially heavy machinery, there could be significant side effects, and maybe even life-threatening side effects, that can occur from seizures occurring at the wrong moment. And just as a person and a human being, it was incredibly humbling, hearing them share their stories with us. But at the same token, it was incredibly validating to just hear them express as well gratitude for a trial, being funded to kind of identify further discoveries about this condition that they live with, and that they, like stated, may have themselves, or that their family members may have. And Reverends Perry and Clayton, as we've talked about as well, it is in these times uniquely as well. I mean, it's hopeful and reassuring to see that the NIH is still doing clinical research in this area, to try to identify an intervention that will help patients and will decrease secondary complications from ongoing seizures, and has great potential for saving lives as well.
I think that's one of the missions that we have, is that highlighting equitable breakthroughs in medicine for people, for everybody, marginalized and other, because in our community, we're the last to hear about. Normally, we are the last to hear about any of these studies until they're on the road and running, and we have no input, and we have no access to the studies. It's just like and a lot of times it just doesn't, coming down from the top, it doesn't always reach the bottom. So, I mean, I'm so glad that, this equitable breakthrough is an equitable breakthrough that's going across the nation, as you said, and that it will help everyone, which is awesome. In my growing up, and you can maybe help me with this, when I was 6 or 7 years old, my brother and we had a seizure. And so my mom didn't know what it was. And so when she took us to the doctor, we were really young, like 5 and 6. They gave us no medication. I don't know if the science has grown, but they just gave us no medication. Mama put her hands on us and prayed to God that
Right.
boys would be all right. And then when we asked her what the doctor told her, and she said, he said, you would outgrow it, not to worry about it. But if it continued, we were to go back to see the doctor. So, when I hear you talking about status epilepticus and seizures and epilepsy, is every seizure an epileptic seizure? Or can seizures be something with the brain or in the brain that just triggers a response, but it doesn't really have a label? And people who do have epilepsy, do they take medication all of their lives? And thirdly, the one that you're talking about is a much rarer one. And I don't even know how you guys, other than the fact that it lasts for more than 4 minutes, how you guys can identify that with a person on their way to the hospital having it, or and then we're never told what to do. I've seen a person have an epileptic episode, and I'm sitting there in amazement, thinking, "Oh my God, is there anything that we're supposed to do?" You lay them on one side. You put. Some people said they'll swallow their tongue, and so our community, we got God right now. It's our major source of medical reference. But now that we have you here, you can maybe give us some ideas of how we should be looking at this and how we should be dealing with this when it happens in our church or in our homes or with someone we love. Is the first thing we do is call 911, or is the first thing we do is to make sure that the person is calm and lightly restrained? I don't know. Can you tell us?
Yeah, these are great questions. And, for anybody who has, seen a seizure, certainly the first time of witnessing that, it can be terrifying. The first time you see anybody who has kind of a change in consciousness, it can be absolutely terrifying because you just don't know if they're going to wake up or return, to prior baseline status. Whether it's onlookers or whether it's parents, as you alluded to from your situation. First and foremost, I kind of learned this when I was a medical student. I worked on the side providing respite care for someone with cerebral palsy who had seizures. So that was really kind of, for me, the first time I had ever seen someone in a seizure have a seizure with convulsions. And I will say, seizures in general, most of the time they do have convulsions with flexions and extensions of the arms and of the legs, with a clamping of the jaw as well. A much rarer subpopulation may not have convulsions, but most do have convulsions. And first and foremost, if you're someone who is seeing someone, have a seizure, the things to think about in the very beginning are, first and foremost, try to ensure that, there won't be any secondary things that happen where, that could hurt them. So if they need to be, lay them down on the floor, remove them from, support them if they're in a chair so they don't fall over on the floor. So try to prevent any secondary effects by which they could be hurt. And then, as you alluded to as well, thankfully most seizures just last for a very brief time period in the continuum of seconds. But when you're seeing that as an onlooker occur, seconds can seem like hours, obviously. But that's a reassurance. So typically what we would recommend is, you have one person there preventing any secondary falls or injuries that can occur during the seizure activity. Someone else can call 911 simultaneously. Oftentimes too, if it is someone with prior seizure activity or a history of epilepsy, you may have family members or other ones who know how to do that because, they've done this before. So certainly, and obviously, listen to what their recommendations are. And then third, like you alluded to, if someone is laying on the ground on their back and you see that they start vomiting into their airway, that's when you can roll them to the side as well to kind of prevent aspiration. Typically, when the seizures stop, patients do have what's called a post-ictal time period. So that's a period of kind of recovery of the brain by which they can still be altered, be in a drowsy state, and not fully responsive to external stimuli, and that can sometimes last for minutes to under an hour. Sometimes it can be longer if the seizure was longer as well. And then when the paramedics arrive, if the seizure is still ongoing, typically they'll check a blood sugar because low blood sugar is something that can cause seizures. And then they will administer the initial medications. For families that have a child with seizures as well, sometimes sometimes parents or older siblings may be trained to give the initial dose of Valium or benzodiazepine medication before EMS arrives as well. So sometimes there could be nasal administration of this as well by family members or other modalities. Now, the other thing that you alluded to, the greater thing that you alluded to, were, which is a very important question, is what are all of the different causes of seizures? And that's a very expansive conversation as well. And kind of as you alluded to first, with seizures in the young pediatric population, one of the most common cause is febrile seizures, by which a virus, most commonly, or other illness can cause a young child to have a temperature that's so high that it can cause typically very brief seizure-like activity. And as you alluded to as well, thankfully, the vast majority of these patients never have another seizure, and the vast majority as well never have seizures when they grow older as well. So that's kind of the grow out of it advice that your mother was given in discussing. There are many other causes of seizures as well. It can be a side effect of medications. There are some medications that can have side effects. There's recreational drugs that can cause seizures as well. There's other, what we call metabolic electrolyte abnormalities that can contribute or cause seizures. Low blood sugar being probably the most common one across the board, but alterations in an electrolyte called sodium can also contribute and cause first-time onset seizures in people. We can as well see seizures, and it's a very rare occurrence, but we can see seizures in patients who are having strokes. Again, that is very rare. It's less than 5%. We can see seizures in people who have traumatic brain injuries. We can also see seizures in people who have central nervous system infections as well, like meningitis or encephalitis, which is an infection of the spinal fluid and then of the brain itself. Again, thankfully, these are very rare things. And then epilepsy is kind of, that is a diagnosis in which seizures are not caused by any of the aforementioned etiologies and really are the result as errors in the electrical conduction of the brain's electrical system. And again, you asked the question and posed the question, when will people be put on medications? The answer is, if people have a seizure that's caused by a known culprit, like low blood sugar or an electrolyte abnormality or side effect of a medication, typically those patients would not need to be put on anti-seizure medications. But if people do have epilepsy, alteration in the brain's electrical conduction system, most patients with epilepsy are put on a medication because the risk of recurrent seizures is higher in the condition of epilepsy. And I did forget to mention too, another common cause of seizures that we see in the emergency department as well is withdrawal from certain drugs as well. Alcohol withdrawal can cause seizures as well, and we treat that with Valium. I don't know if you had other parts of your question. If so, happy to address. I can't recall if I addressed everything that you posed. So
that's amazing. I was thinking in the Bible, there was one young man in the Old Testament in Kings. He was out helping his dad, and he got sunstroke. And I kept thinking maybe this was a seizure, an epileptic thing. And they didn't have a doctor like you to help them, so they went to the prophet who did some kind of respiratory thing with them. He kind of laid on top of them, maybe pressed the heart or something to get things back to moving, and revived the child. But when you talk about babies who or young children whose temperatures, I really didn't think about that. When a temperature in the child gets to be above a certain level, I didn't know if they were more likely to get seizures, strokes, or and I've seen people with high temperatures and people would put ice around them or give them Tylenol or something to kind of to lower the fever. But that can cause strokes and seizures, that high temperature.
Well, high temperature, it can't cause strokes in terms of like the blood vessel blockages or the bleeding hemorrhagic strokes. But you certainly alluded to heat stroke, which again, kind of in that setting of like severe dehydration, you may have abnormalities of electrolytes too, which may be contributory. Thankfully, heat stroke in its own right is, relatively rare. Certainly more prevalent in the southern states than northern, but still is relatively rare. And again, typically seizures is a very rare complication of heat stroke as well. The most common thing that we see with heat stroke is just a change in mental status or confusion, as opposed to, say, overt seizure activity. In terms of the febrile seizures for pediatric patients, again, that can be a terrifying thing for parents to see. The most important thing I would recommend, in general for your listeners is that, if they have a young child with, fevers and signs of infection, reach out and talk to your pediatrician and your provider, because you want to come up, as you alluded to, with a good management strategy using Tylenol and sometimes alternating Tylenol with Motrin to keep the fever down so it doesn't get into the higher thresholds. So that's something certainly that is a recommendation for all of the listeners here, to engage your healthcare providers.
Dr. Werner, hold on, stop 1 second. You mentioned Tylenol. Didn't we just hear something on?
Yeah, right. I know.
Don't go there.
We won't go there, but I'm just saying.
Yeah. Well, I will. Yeah. I mean, we could talk about that, but Tylenol, for the most part, it is a very safe medication. In the emergency department, it is our first line for pregnant patients too. It's safe. We do not want, other medications to be taken, in the time period of pregnancy, but that could be a whole separate program in which we talk about that. So
I do have a thought. About 12 years ago, we after church service, man, he was there, seemed to be in very good shape. He was in good spirits. He left the service, got in his car, and headed home. And just one of those days, I happened to be going the same way he was going, and he hit a car. And he kept going. And about a mile up the road, he hit another car. I'm blowing the horn, and he hit a telephone pole, and that's where he stopped. And we found out later that he had a seizure. My question is there something or some way that a person feels before that happens? Because I'm pretty sure if he felt sick, he would have said something. But he was laughing, his normal self. Then all of a sudden, bam, a mile and a half, 2 cars and a telephone pole.
That's terrifying. Because obviously, if it was on, obviously it was, posed a great danger to him, but to other people as well. And certainly if he was on a highway going highway speeds, that the acceleration of speed, enhances the risk obviously as well. And this was a first time onset seizure. Is that what I had
as far
understood?
As we know?
Yeah, it can be, there are, as you allude to, I mean, this is a really great question as well. There are a small proportion of patients who have established epilepsy and, again, kind of known established recurrent seizures. And again, myself being in emergency medicine, I can't answer this question as well as, say, a neurologist. But there are a small proportion who may have, warning signs like what we would call aura, where they may see flashing lights or, have abnormalities in smell. Sometimes as well, you can have, kind of service animals or dogs that can, also in some circumstances, recognize the warning signs as well and have the person, kind of sit down and be in a safe position. But the vast majority of patients do not have those warning signs. And certainly people, with first time onset seizures, usually when, they really don't manifest a consistent warning sign, before first time onset seizures that we can distribute as kind of like a health awareness. So again, to kind of like, answer your question first and foremost, most patients don't have warning signs, and first time onset seizure patients, it's so hard, to kind of, sometimes even establish if someone did have a seizure from a situation like that. But the warning signs are really not something that regrettably appear to have a high enough frequency to disseminate to the public. As you said, when someone like in your parishioner's circumstance has a car crash, sometimes one of the first things that EMS says to us, or a question that we ask EMS as well, if the patient was unconscious when they arrived or didn't have recollection or had amnesia to the event, one of the key questions to ask is, were the brakes applied? Were there brake marks at the accident scene? Before that telephone pole that you alluded to, because if there are brake marks, then that suggests that the person, at least before the accident, had the wherewithal and alertness to kind of know that they were about to. But if there were no brakes, then we have to worry. Was there a fainting episode, maybe related to cardiac causes or other causes, or was there a seizure episode that occurred as well? And we typically, the workup for a first time onset seizure occurs in the emergency department. We basically do a brain scan with a CAT scan. We check multiple labs, electrolytes, blood sugar, etc., other labs if applicable. And then typically we can discharge patients, but we have to place them in what's called seizure precautions, which, that is, that's a potentially life-saving, intervention in its own right there. The seizure precautions mean no driving, no swimming, no operation of heavy machinery, by which if an event happened again, it could have dangerous secondary effects on yourself or potentially for others as well. And then we do outpatient follow-up with our neurologists to get what's called an EEG. So that is a measurement of looking at all of the brain waves, the electrical waves of the brain, to see if there's any abnormalities that may suggest the risk for recurrent seizures. And then depending upon that workup, patients are either started on medications or not started on medications.
Now,
That's amazing.
yes. Do you see ketamine eventually being used more for emergency seizure control, or as a chronic therapy?
More for acute emergency control, because, like alluded to, it's not something that, ketamine can only be administered really through an IV or through an injection. So it's not an oral medication that can be used at home. So really this trial will discover if there's benefit for its use in the emergency department setting only. Now, if the trial does have positive outcomes, the next question would be, could there be benefit of moving it up even sooner? Because many states have policies by which ambulances and EMTs and paramedics may be certified to carry and administer ketamine. And some of the preliminary studies that have been done demonstrate a signal of benefit for potentially having EMS or ambulance personnel give ketamine in the early setting. So that potentially could be a secondary follow-up trial that's done if we get a positive outcome from this trial. Because again, the longer a seizure occurs, the greater the likelihood for side effects like brain injury or low oxygen status or needing a breathing tube, or other adverse effects of continuous ongoing seizures. So if we can break the seizure in minutes rather than say hours, or even in some circumstances, days, because we have had patients who have had seizures for days and even more than a week. If we can break that seizure sooner, outcomes are dramatically enhanced. And I will say, this was a case that was published at Yale by one of my colleagues in neurology, but there was a patient in the ICU setting who, after a cardiac arrest by which their heart stopped, they had ongoing seizure activity that was refractory to 5 other medications for several days. And it wasn't until a continuous IV infusion of ketamine was started that the seizure activity finally stopped. And then the patient was able to have kind of tactile responses to the team. The breathing tube then, a day later, was taken out, and the patient was able to walk out of the hospital. There were still, because of the duration of seizures being almost a week, there were still some subtle cognitive effects of that at the time of discharge. But the patient, did not have the seizures break until the ketamine infusion was started. And so that, in addition and in combination with the other studies that I'm kind of alluding to, gives, I think, all of us participating in this trial great hope that moving this 4th or 5th line agent ketamine up to earlier administration, gives great hope that we will, find something that can help our patients. So
That's awesome. I just want to reiterate what you said. You cannot sign up listeners for this study. You can opt out of the study, I guess, through Epic or something like that. But from what we've heard today, you don't want to opt out of this study, because this could be life-saving and a breakthrough for all of us and all of you. So again, we just want to thank Dr. Werner. And Doctor, you said they could go to your website if they want to learn more about this, or?
Yeah, so we do have a Yale website that's been created for this, so they can go to our website if they want to learn more information or potentially opt out. There is an email address that we've set up. It's called keset@yale.edu. So that's KESSETT@yale.edu. They can email us if they choose to opt out. And for the opt-out procedures, if people do choose to opt out, the Central University of Michigan and Alabama sites that are operating the trial nationally will send a bracelet that can be worn, and then we'll have other internal ways to kind of ensure that we don't do anything that people would not have wanted. So
The mere fact that the consent form through the IRB or whatever has allowed you guys to do this study also shows how important it is and the efficacy of safety that they've had that would allow you to do that. And I think that's notable.
and I will add too that once family arrives and once patients come around and have the ability to provide consent, there will be an informed consent process for continuation in the trial. And what does that mean? That means that for the other things that we're doing in the trial, blood draws, following the hospital course to see how things are are going. So there will be a consent process for continuation in the trial that will be acquired fairly early when family arrives at the hospital. So,
And will emergency medical teams already have this information about this? About
yes,
the
yes.
hospital? And you said, what hospitals will be available? Is it only St. Raphael in New Haven? And there was another one I think you mentioned. Will there only be 2 or 3 hospitals in the area?
Yeah, thanks for mentioning. So it is projected that the trial is going to be going on for 4 years. It's going to enroll 770 patients at the 60 sites. And we are first launching the trial at our York Street Adult Emergency Department. We are working closely with emergency physicians and neurologists at the Children's Hospital as well, and we hope soon after the launch in the fall or winter at York Street to also open the trial up at the Children's Hospital. And then further down the line, we hope as well to open up the trial at the St. Raphael's campus. And so the ultimate goal is, yes, as you alluded to, that all 3 of our Yale Hospital sites and emergency medicine sites in the New Haven area will have the ability to screen and enroll patients in the trial.
Listen, we need to make an acknowledgement here right quick. We want to thank our listeners again for tuning in. You are listening to the YCCI Community Health Watch Show on WNHH 103.5 FM.
Yeah. So, Dr. Winters, when we call 911, will they direct the traffic to those 3 hospitals once they identify what the issues may be?
This study will not alter 911 traffic or dispatching or transfer to hospitals. We want obviously as a system, we want patients to get to the closest hospital possible so as to be treated first. But so we will we really don't start screening for the trial until patients are brought through the doors of our emergency departments. That's kind of the necessary prerequisite thing that occurs. Maybe in the future we'll have a second version of this if the outcomes are positive for ambulance or paramedic administration, but that would be years down the line. So because like stated, this trial is going to be 4 years, and it would be at least 2 or 3 years before something like that got off the ground and funded.
I only say that because I know that, like, when I was in New York, there were certain people, you could go to Columbia Presbyterian, you could go to Harlem Hospital, and they would tell us, they said, well, if it's a knife or a gunshot, make sure the ambulance takes you to Harlem, because this is what they specialize in. They have a great record of that. And I was just thinking that if I had a child who had this seizure and they just sent him to any regular hospital and it was status epilepticus, they might not get the treatment that your study would offer. That was my observation.
Yeah, no, that's a good observation. The reality is, we do not want clinical research to be detrimental to the standard care that's provided. And so if patients are, within Connecticut or elsewhere, kind of closer to another hospital where EMS typically goes to, that's the first priority. Good clinical care is obviously the first priority. So,
will you expand that to the other hospitals outside the 3 that you mentioned as the years go on? If they show that the study has positive potential, might that be something that you guys would look at in terms of your overall outreach?
It certainly is possible. We do partner with other hospitals within the state for this clinical research network. Our hub, which is a part of this clinical trials network, we kind of work with other hospitals from New York all the way up to Boston. And so we do have 2 other sites right now in our hub and spoke network that are considering the trial. One in Massachusetts, 2 in Massachusetts actually, and 1 in New York. But certainly, if there's healthcare providers that are listening and, would like to potentially be a site within Connecticut for this trial too, we're happy to talk and explore possibilities. So
See that? Now we're talking.
mhm.
You got to think outside the box in order to
Right.
to get the best results. So I really do appreciate you being on this show, and I'm hoping our healthcare professionals as well as our community listeners will take hold of this information and pass it on and spread the word that this good work is being done. That's what we call gospel, good news.
Mhm.
Good news. We're almost running out of time. Doctor, you have any closing remarks you want to leave with our listeners?
No, I just want to thank you for the opportunity to be here to, share the work that we're going to be starting. And again, it offers, light and hope that, the NIH is still funding research like this for very important disease conditions, so as to identify new discoveries, to help people with conditions such as this.
Awesome. Thank you. Reverend Clayton, you have a last word? We got 1 minute left.
Just want to thank Dr. Wire for coming on today and sharing this great information. Doc, how can our viewers and listeners reach you?
Yeah, I think the best way is, for the trial is through the trial's email address or website. So if they just go into a Google account and type epilepsy trial Yale ketamine, they should find our clinical trial website. And again, as discussed before, we have a keyset@yale.edu email address by which people can email our coordinator and myself directly if they have questions. So
Awesome.
I don't know if that can be shared, maybe on the reruns of this broadcast, but we're happy to.
You're listening to the Community Health Watch Show on WNHHLP 103.5 FM, your home for community radio. Stay informed, stay connected, and take charge of your health. We'll see you again next time, right here on the Community Health Watch Show.
All right. Thank you, Doc.
Yeah, thank you so much.